Thank you, Cyrus. Good afternoon, everybody. It's truly a pleasure for me to participate in this meeting. It's been a long time since I've been here. This has been a terrific session on femtosecond laser cataracts. Congratulations on putting together such a good course. My topic is femtosecond laser in challenging cases, and these are my financial disclosures. When we think about complex cataracts, especially in relation to the femtosecond laser, there's clearly advantage in using the femto laser in these conditions listed here. And of these, for instance, in Fuchs corneal dystrophy, you're not really making too many changes on the femtosecond laser. The advantage stems from the fact that you can use very little phaco energy. And in these other cases, you just have to customize where you're creating your capsulotomy. And so I'm going to focus on the top two indications here where femtosecond lasers clearly have an advantage. The first of those is subluxed cataracts, and in these situations the laser has to be adjusted so that you can maximize its capabilities of customizing the position of the capsulotomy to your advantage. And let's discuss that in more detail by talking about a specific example. This is a patient who had 6 clock hours of zonular compromise. And the primary goal, therefore, was to create a capsulotomy without zonular stress so that you could then stabilize the capsular bag with hooks. And so with the laser, in such cases, what you really want to do is ensure that the laser is correctly identifying the anterior capsular position and the posterior capsular position. And to do that, you move the calipers down so that the lens is correctly identified. Like you know, in this situation, the lens has an abnormal position, and sometimes the laser is able to pick it up, but sometimes you do have to confirm that indeed the laser has correctly identified the anatomic landmarks of the lens. And once you do that, the laser is able to create your capsulotomy. In this example, you can see here that the laser has nicely created the capsulotomy that we wanted it to create. These are situations where you really want to be certain that you are indeed carefully ensuring that the capsulotomy is complete. So you want to use your capsulorhexis forceps and carefully tear so that if there are any tags that remain, you're not letting those go radially. Thereafter, once the capsulotomy has been created, the next step is to stabilize the capsular bag. And that's a standard procedure that we use in anybody who has zonular lysis. And here we've inserted a capsule tension segment. There is a suture that goes through the eyelet of the capsule tension segment that comes out here. And so once we've placed the capsule tension segment accurately, we go ahead and tie the Gore-Tex suture. And you can see here that the capsular bag has nicely centered once the Gore-Tex suture is tied. So essentially in this case, where the lens was displaced quite significantly, by creating the capsulotomy, we are able to then proceed and stabilize the capsular bag with the capsule tension segment. And this is another example that we published with the Grewal group. And you can see here a large area of zonular dialysis. And once the laser has created its capsulotomy, we place capsule hooks and then stabilize the capsular bag. What are the things to keep in mind in such cases? Well, there are really a few nuances that are very, very critical for a successful outcome in such cases. The most important consideration relates to settings of the laser, and in such cases you want to make sure that you're using maximum energy so that the penetration of the laser is complete. Like you know, there is some tilt to the lens, and if you have the usual settings, you sometimes will not get a complete capsulotomy. So making sure that you're maximizing the energy and providing accuracy with how you're locating the calipers will ensure that the capsulotomy created by the laser is complete. And that's what I'm highlighting here. We're making sure that the incision depth is more than the usual. Normally we have an incision depth of 500 microns, and here we're increasing that again to maximize the chance that the capsulotomy is complete. And that's what we are doing here. We are customizing the position of where the capsulotomy will be created so that the capsulotomy is nicely centered on that decentered bag. what are the other facts to keep in mind in such cases? Well, this is a bag that's already somewhat compromised because of the zonular weakness, and so you want to make sure that you're not creating excessive gas inside the capsular bag, and so you want to set the repetition rate to 1. If you set the repetition rate to a higher level, you will get a better cleavage of the nucleus, but you'll create a lot more gas. And so in such cases, to minimize gas production in the capsular bag, I will not usually be using softening. What are other elements to keep in mind? Well, make sure that your capsulotomy is not very large. These are cases where, because of the zonular weakness, the lens is tilted as well as displaced a little bit to the side. And if you try to create a large capsulotomy, what often happens is that the edge of the capsulotomy is very, very close to the equator, like you can see in this example. So make sure that you customize the size of the capsulotomy so that there's an adequate frill of anterior capsule peripheral to the capsulotomy all over. In this example, I used a capsulotomy size of 5 millimeters, and I think I would have done better if I had used a capsulotomy size perhaps of 4.5 millimeters. And that's on the smaller side clearly, but then it maximizes the chance that you can stabilize the capsular bag. The other caveat is, there's always vitreous in such cases, and sometimes anterior to the capsular bag, in which case you have to do an anterior vitrectomy. And I think it's really important in such cases not to be too aggressive with your anterior vitrectomy. In this example here, I am making sure that I do a complete anterior vitrectomy, and what that's done is it's caused the lens to tilt back much more significantly than it otherwise would have. So I think I would have done much better if you'd done certainly a vitrectomy to remove the part of the vitreous that's in front of the capsular bag, but not to be too aggressive with it. What are the other factors to keep in mind? Really important to stabilize the bag adequately before you proceed to phaco. In this case, we had global zonular weakness, and in such a case, my plan was to place a capsule tension segment, which we did after the capsulotomy. And you can see here that even though I have a capsule tension segment and I have the suture tightened, you can see the capsular bag is nicely moving, and that's because this is someone who had global zonular weakness, but I placed just one capsule tension segment here, which means that the capsular bag, in spite of placing the segment, has significant tilt, in which case the capsule tension segment can slip back. So important to keep in mind in cases like this, to ensure that you are placing at least 2 or 3 segments or 2 or 3 hooks so that you are providing diffuse support to the capsular bag. So to summarize, the main take-home points in subluxed cataracts is not to create a large capsulotomy, not to be too aggressive with your anterior vitrectomy, and to make sure that you're providing adequate support to the capsular bag. If you have global zonular weakness, you really want to make sure that you are providing circumferential support to that capsular bag before proceeding with nucleus removal. I have 10 minutes for my lecture, and so I'm going to talk about posterior polar cataracts briefly. The good news is that Shreyas talked about it, so I'm going to be brief in my comments and perhaps add to some of the things that I think can be useful to keep in mind that Shreyas didn't touch upon. So the first clue in this case is to make sure you very carefully inspect the OCT, and you can see here that there is a posterior capsular dehiscence. In this case, in this example here, the posterior capsule is intact, both posterior polar cataracts. The second point to keep in mind is to minimize hydrodelineation. Shreyas talked about this, and so I'm not going to go to that point. But I do think that in posterior polar cataracts, it is useful to also segment the lens. If you really look at it, segmentation extends well beyond the capsulotomy and towards the pupillary margin. So the amount of epinucleus that is indeed cut by the laser is much more extensive if you also do segmentation in posterior polar cataracts. And that's really the point that I wanted to make. I do think segmentation is advantageous. In this example here, we have a posterior polar cataract. We have not hydrodissected this case. And the goal in these cases is not really to rotate the nucleus aggressively. And so what we are doing here is using the segmentation pattern that the laser is created to hold the nuclear pieces after it's separated by the spatula. And you can see here we will go circumferentially without really rotating the nucleus, and that becomes possible here only because segmentation has cleaved the nucleus well into the mid-periphery of the lens. And you can see here that each of the nuclear sextants, like we call it, we made 6 pieces here with the femtosecond laser, nicely separates because of that segmentation pattern. And the second advantage of doing it this way is that you do not have a very large epinuclear sheet out in the periphery. If you don't segment, that is one of the disadvantages, like with the Lens X laser. If you just create the cylindrical pattern that we talked about previously, that leaves much more epinucleus for you to manage, whereas if you segment, you have just the thin sheet of epinucleus outside of where the posterior capsular plaque is located. So the critical points with posterior polar cataracts that I wanted to highlight: inspect that intraoperative OCT very carefully, ensure that you also segment the nucleus, and make sure that when you set the laser settings, increase the safety zone so that the likelihood of going to the posterior polar plaque is minimal. In these cases, you do not want to soften. Thank you very much for your attention.
Thank you, Dr. Basti, for a wonderful talk and for coming all the way from the US and speaking to us on this topic.
Thank you.